The emerging health and economic risks resulting from the COVID-19 pandemic and decline in international oil prices pose threats to Nigeria's economy as well as its healthcare system. And the federal government at several meetings has identified plans on how to reduce the burden of the virus and its impact on the economy through various interventions.
Thank you, and sit down.
The latest of such is coming from the Ministry of Finance.
Can we clap for her?
Besides the 500 billion naira intervention fund, the government is proposing other measures to help state and local governments withstand the shocks of the pandemic.
With regards to the special works programs, Mr. President has previously approved pilot special works programs in 8 states to be implemented by the National Directorate of Employment, the NDA. This approval was given in early this year, and the works were supposed to take place between February and April 2020, and I'd like to report that these works are currently ongoing. Mr. President has now approved that this program be extended to all 36 states and the FCT.
That is not all. There are other palliative measures to assist the poor and vulnerable.
The President has approved drawings from the Strategic Grains Reserve. The Nigerian Customs had in its custody a lot of rice that has been seized, and there's 150 trucks of rice that is now being handed over to the Humanitarian Ministry for distribution to the states across the Federation.
A total of $3.4 billion is expected from the International Monetary Fund, $2.5 billion from the World Bank, and $1 billion from the African Development Bank.
We have also applied to the International Monetary Fund for its COVID-19 rapid credit facility to draw from our existing holding within the World Bank IMF group. This loan will not be tied to any conditionalities. However, let me just state here and clarify that Nigeria does not intend to negotiate or enter into a formal program with the IMF at this time or in the foreseeable future.
The effects of COVID-19 is still taking its toll on the nation's economy. But interventions such as these can only be described as timely in reducing the impact.
All right, welcome back, but we'll talk about that in a moment in terms of the finances, cushioning the effects a little later. But we do have Dr. Mukhtar Dati Ahmed, who is a consultant surgeon and clinical director for surgery, Pool Hospital in the UK. Good morning, doctor. Thank you for joining us today on the program. Well, let's start off with developments over there where you are. I mean, the news broke yesterday about the Prime Minister having been moved to intensive care. So could you tell us, what is the current feeling, the mood in the country about his situation at the moment?
Good morning, and thank you very much for having me. There is clearly a lot of concern about the Prime Minister's health. There have been expression of good wishes and prayers for his recovery from all facets of life, all across the country, and we hope that he recovers well to continue to lead the fight against COVID-19.
While he was at home, many were of the opinion that, yeah, being the Prime Minister, he'll be getting the best of care, but having then been moved to the intensive care unit, what kind of circumstances could warrant that?
So in general, we know that the cause of this virus is that when you contract it, most people will have a very mild illness in that they will have a cough or a fever and feel unwell, fatigued, but will generally recover. If you're going to recover, you generally tend to do so within 7 days. A small proportion of people, mainly people with other health conditions or much older people, will then go on to have some complications of the virus, like a pneumonia or inflammation of the lungs, which then leads to a difficulty with breathing that might require support in hospital by oxygen therapy, non-invasive ventilation, or even going on to invasive ventilation.
You know, when general public get to hear that kind of information, even globally, they tend to wonder, oh, whoa, wait a minute. So it means, yes, it is new. Now we don't even know what to expect. So do medical experts get the same feeling that you constantly have to be on your toes when dealing with patients and handling such cases?
Yes, absolutely. I mean, this is a new disease, and we're learning from it every day, particularly from those who are ahead of us in their COVID-19 journey in China, in Italy, Spain, and other countries, in the US and other countries around the world. We know that in general, it is transmitted by human-to-human contact. Hence the importance of the social distancing guidance that has been issued by the WHO and implemented here in the UK and in many other countries around the world. We know that there are concerns about other forms of transmission through other body fluids. We generally feel that it is transmitted through what we call droplets, through the respiratory tract by someone coughing or breathing near you or sneezing. And in general, staying away from people who are not members of your immediate family is the best way to avoid it. Coming to healthcare professionals, clearly there is a concern that we are at high risk, and indeed in the UK and in many other countries, in like Italy, for example, 8% of the cases that have suffered the consequences of this virus have been healthcare workers. And close contact with somebody who is actively unwell with the virus clearly increases your risk of having COVID-19 yourself.
What, in your opinion, from your experience so far fighting this disease, what, in your opinion, is the most challenging thing that healthcare practitioners like yourself have had to contend with? What's the greatest challenge in the fight against this coronavirus disease?
So the greatest challenge, in my view, is first of all the varied presentation of the virus. We know, for example, where I live in Dorset in the UK, we have a very elderly population. And amongst the elderly, the symptoms of the virus could be atypical. So they could sometimes just present to hospital feeling unwell, but without the cough, without the fever. And we, as healthcare professionals, at the initial phases of this pandemic here, were not switched on to the fact that they could present with symptoms that are not typical. And as such, we potentially put ourselves at risk. That is evolving. We know that children, again, present in atypical ways, though they tend not to suffer significant consequences of the virus. The second concern is that of personal protection. And the guidance on personal protective equipment has evolved through the course of the pandemic. We started out in a situation where there was a lot of concern that healthcare workers were not adequately protected. I think we are satisfied now that across the UK, certainly where I practice, there is no concern about supply of personal protective equipment, and there is clear guidance about where to use it and a lot of training about how to use it, how to put it on, and how to take it off to reduce the likelihood of infection. But we know that there is at least a 10% sickness rate in the National Health Service, the public health service here in the UK. For we know that the rate of transmission, certainly in the healthcare setting and in care settings and people working in nursing homes, is higher than within the community. And that leads to a concern about resilience, that if we start getting health workers being sick themselves and being off work, who then, looks after those who need the care in the hospital. So the important thing is applying the social distancing rules and a lot of testing. So testing people who fall into the categories that require testing, particularly prioritizing healthcare workers for testing.
But there is also talk in some quarters, you may have also heard, that the fight against this COVID-19 is sometimes peculiar or typical to different geopolitical zones or different countries. Is that also a challenge for healthcare workers, making comparing notes sometimes difficult?
It does. It's a very good question that you ask, because we know that culture plays a huge role. The WHO's guidance is very clear for every country around the world, is to do social distancing, test and test and test, as the WHO has implored us all to do. But we know that, there are different levels of engagement with the authorities in different countries. We've seen the success of Korea in controlling this very quickly. And we know that the Koreans generally quite, are a very obedient population. They're used to being given instructions, and they have a very centralized government. And they've dealt with previous pandemics like this. They have lived through wars or threats of wars. And in countries where they are very centralized, it is easy to follow those sorts of instructions. We've seen the situation in the United States, for example, where, because you have a federal system similar to our system in Nigeria, with every state potentially making different decisions, that it could be a challenge where one state is taking quite stringent measures and another state chooses not to take the same measures. But the outcome in one part of the country could affect that in another. There is also the question of socioeconomic status. And in lower and middle income countries, there's no doubt that adhering to regulations like social distancing and the lockdowns that we've seen in some countries, say in India, for example, cause quite extreme hardship amongst people who are daily wage earners that have to go out to earn a wage. We have in the UK a social net. The government has budgeted hundreds of billions of pounds to support the economy and to support those who are not able to work. So it's easier in an advanced economy like the UK to apply the rules of social distancing, because people can fall back on the support of the state to feed themselves and to keep a roof over their heads during this difficult period.
I was looking through some figures, and yes, Nigeria has 238 cases. In the UK, it's about over 51,000 cases. But what was also worrying is the fact that the UK was at this point where Nigeria is right now just about a month ago, and now 51,000 cases. That's 200 times or more than what Nigeria has right now, like times 200. And the big question is, yes, it might be difficult to compare notes, but even at that, there's still something we can learn from other countries here and there. So if you could just, give some lessons here such that Nigeria will not get to that point in a month's time. What can Nigeria learn from the case of UK? How can we curb the spread, flatten the curve, and ensure that this dips even much further?
I have worried that the response has been too slow. I recognize that we have challenges in terms of our population, in terms of engagement. But the most important lesson is to learn from those that have gone before you. The one predictable thing about COVID-19 is it seems to follow quite a predictable course. It starts off slow and then it starts to increase exponentially. We've seen the way the deaths have crept up, and you've absolutely quoted the correct figures in terms of how it seems to increase from a very low level. And you can predict, looking at the countries that are ahead of you on that curve, where you're going to be in a few weeks. And you're quite right now. In the UK, we've tested over 200,000 people, 51,000 positive. And of those, we have a 10% mortality rate. And this is in one of the richest countries in the world, with quite an advanced, public health and secondary health system. So the important thing is to implement those measures quite stringently, to ban public gatherings and to enforce it, to reduce, to give people the support that they need to be able to work from home or to stay at home. Because if one has to fend for his daily bread, it is unlikely that they will adhere to these rules to stay at home and be hungry. So if the government, it's a two-way thing. The government can impose these rules, but you have to give people the support that they need to be able to to stay at home. The third thing is to prepare the health system and to work as a network, because no state in Nigeria will be able to cope with this alone. The government has to learn from the lessons in other parts of the world and set up the country into different, and we already organize in geopolitical zones in Nigeria, to set up, hubs where there will be close coordination with the bodies leading it, like the NCDC, and select facilities that will have the higher levels of care, provide training. We have a very skilled workforce in Nigeria. We're not in need of skilled doctors and nurses. We have very skilled doctors and nurses. I travel to Nigeria a lot to teach and train and engage with people. But what we're lacking is the resources, is the facilities at secondary care, and also the primary health system. Though I must say that, we've recorded successes in Nigeria before with controlling Ebola and other infectious diseases like Lassa fever and polio, and we could build on the resilience of those systems that still exist for surveillance and to maintain vigilance. But if it gets to a point where we have many people being admitted to hospital, we will have to significantly ramp up the provision of equipment, facilities, and pool resources to where the problem is greatest, because we will have hotspots.
I'd like to take you up on care briefly. I mean, care for patients who have tested positive for COVID-19. I recall the Commissioner for Health in Lagos last week saying that, well, there's been no need for ventilators so far. So it would seem as though, the care being given to these patients in this part of the world, might just be working. But that, compared to what you have in your country, for example, we've seen, ventilators being used time and again for patients. So I'd like to know, is there a standardized form of care for patients? Are we doing the same thing you're doing there? Or I'd like to know, what kind of care are you giving and what might be happening here in Nigeria?
Yeah, so just to be clear, as I said earlier, this is generally a mild illness. For most people, they will suffer what will feel like a common cold, like the flu, and they will recover without even needing to be in hospital. Now, a small minority of these patients will go on to develop complications and difficulty breathing that will require initially at the first level just oxygen, supplemental oxygen therapy to help them breathe better. If they continue to struggle, because what the virus could do is to make the lungs stiffer or to make them partly fill up with fluid, which makes it difficult for the lungs to take on oxygen into the blood. Now, when it gets to that level, the next level of care that my colleagues who work in respiratory medicine and intensive care will be looking to give these patients what is called non-invasive ventilation. So this will be given through a mask on the face that will give oxygen at higher pressure to try to open up the lungs to help push the oxygen into the system and to keep the air cavities in the lungs open. If all that fails, then the highest level of care is to then insert a tube through someone's throat into the airway to give them mechanical ventilation. So they'll be sedated, so they'll be put to sleep, and then a machine will be pumping the oxygen into the system and allowing the exhaled air to come out. So this is resting the system and taking over its control of breathing. Now, it has been noted, some experts have noted that the disease seems to be milder in sub-Saharan Africa. We must say that our numbers are small. We haven't tested many people, so it is difficult to make a judgment on such a small sample. But so far, it would appear that the vast majority of people who have tested positive in Nigeria and other sub-Saharan countries appear to have the milder form of the disease. But then that was the case as well in the earlier part of the journey in other parts of the world, including developed countries. So it is wise to prepare. We hope that we don't get to the level where we need thousands of ventilators, because we don't have that capacity at the moment in Nigeria. But it is quite possible that the disease is behaving in a different way. But that is not a reason for complacency, because, as I said, we're still very early in our journey.
There are lots of conversation going on out there about treatment, managing patients, and then this one, hydroxychloroquine, azithromycin, zinc sulfate. Do they work?
So there are many trials going on. In the UK at the moment, these drugs are only given in clinical trial situations. So in carefully controlled situations where some patients get it and some don't, looking at what the efficacy of these drugs are. I know that in other parts of the world, that there are different rules that have applied, so they have been used in other places. We know that in small trials, one of the ones that is often quoted were carried out in France, and they found that in a proportion of patients that were given chloroquine, after a few days, the viral count in the blood was lower than in those who were not given chloroquine. So it certainly holds promise, as do many other medications that have been tried. But we've got to be clear that at the moment there is no convincing evidence that any of these drugs work, and particularly that they do not work in the preventative setting. And I know for certain that quite a few people in many other parts of the world have been taking these medications as a preventative measure, and those certainly would not work and could potentially even cause harm. And these should only be given on the advice or taken on the advice of a healthcare professional.
Part of different countries, different regions now, they insist that people must wear masks, when they move around, and then you could have gloves to prevent so many things going on. But do you have any information about how much viral load does one need to have before you get infected?
So it varies. We know that when you're in the acute phase of the illness and you have a febrile illness or you have a cough or you're unwell with it, you're more likely there isn't a precise number, you're more likely to shed the virus. And that is the reason behind the self-recommendation. Symptoms, you're days from when and it is when you the viral load starts to reduce, and by about 7 days it is unlikely that you will be able to infect anybody. We know that it is likely to be dose dependent, so the more you're exposed to it, the more likely you are to get it. And the proximity matters as well. So we think that if you're farther than 2 meters away from someone who has it, you're unlikely to get it, even if that person is positive. Hence the rules about the social distancing. And we know that, if you're in contact with someone who has it, if you're going to acquire the illness, it is likely that will happen within a 14-day period. Hence the recommendation that if you are in contact with someone who has symptoms of COVID-19, whether or not they have tested positive, that you isolate yourself for 14 days. But if you have the symptoms yourself, then you only need to isolate for 7 days.
Just before we let you go, you spoke the other time about the brilliance of Nigeria's medical practitioners, and you also said that, how much you have interfaced with them and the kind of brilliance that they have demonstrated and all of that. And you also said the other time that it's difficult to compare notes given the different ways in which COVID-19 manifests itself in different regions. So you are also not unaware of that advocacy, the back and forth between medical practitioners here in Nigeria. Government is saying they want to bring in some medical professionals from Asia, while the medical practitioners themselves, the health workers, the NMA in particular, is against it, bringing Chinese medical practitioners into Nigeria. What's your take on it? What do you think?
think there is a difference between seeking advice and providing support for our healthcare workers from others who have experienced COVID-19 and are starting to recover from it, like in China. So technical advice is a different thing, which I would encourage, but bringing in medical practitioners instead of our own practitioners, I think is a retrograde step. Our health professionals, all levels, from doctors, nurses, healthcare assistants, are highly skilled. They work in a very challenging environment, and many of us that go out to work in Nigeria, I trained in Nigeria and I worked there briefly before I left for the UK. And when we go back, we really admire their tenacity, and their creativity in working with limited resources. And I don't think that is a positive step, bringing in health professionals to replace our own health professionals, but bringing in technical advisors to advise us about the lessons that they learned in places like China is certainly a good thing. It's better to learn from others than to learn from our own mistakes.
Thank you very much indeed for your time this morning.
Thank you for having me.
All right, and we'll be back in just a moment. Stay with us.